Hi, I am Sophie Barbant. I'm the medical director of the Cardiology Clinic and Non-Invasive Cardiology Laboratory here at Highland. And I am going to talk to you about the approach to chest pain. The objectives is to provide a systematic approach to managing chest pain, and it will be targeted mainly to starting interns. Here you are, you're the on-call backup intern. It's one of your first nights and you're called by the nurse at 1 o'clock for a patient on the floor who has chest pain. I hope you don't look like that. You are now at the bedside after having talked to the nurse briefly and figuring out small details and whether the nurse can do an EKG. And the most important thing to do here is to figure out if your patient is stable. So what are you going to do? You're going to assess the vital signs briefly. Is my patient hypotensive? Then is my patient having shortness of breath? Is he in pulmonary edema? Does he have cardiogenic shock? You're also going to look at the urine output and if the patient has altered mental status, which could be indirect signs that there is a cardiogenic shock. And then you're going to assess the rhythm if there is a monitor, and if there is no monitor, either look at the EKG or place the patient on a monitor bed. The senior resident most likely by that time will be with you. And you also have the possibility to call the rapid response team and, of course, code blue. Here you're having a patient who has ventricular tachycardia. Now that you're relieved and that your patient is hemodynamically stable, the most important next step is to figure out, is it likely an acute coronary syndrome, and also rule out other very dangerous diagnoses. So what are you going to look at? The nature of the chest pain, the clinical context, the EKG, and the labs. And all of these items are equally important. And one thing I want to say is don't jump on the EKG. Look first at the history. Good history is key. Looking at the patient is key as well. If you see a patient who is showing you a fist describing their chest pain, that's the Levine sign, then that's very suggestive of an acute coronary syndrome. And by history, a chest pain radiating to the left arm or both, of course, or the neck or the jaw is very telling. You have to ask the patient, is it similar to a prior cardiac pain that they may have had in the past? Is it squeezing in nature associated with nausea, vomiting, or diaphoresis? And a chest pain that lasts more than 10 minutes is also very suggestive of an acute coronary syndrome. If they tell you it just lasted 1 second, that's very unlikely. So unlikely for an acute coronary syndrome. Once again, look at your patient. This time, they are pointing to the pain. That's not likely to be an acute coronary syndrome. And by history, a pleuritic chest pain, sharp or stabbing, if they're using this vocabulary, that's very unlikely, although possible still. Positional chest pain or reproducible. Clinical context is very important as well. Look in the chart. Ask the bedside nurse. They know a lot about the patient. You're going to look at the reason for admission, the hospital course, the comorbidities, the risk factors, and also the labs, some of the labs, quickly. What's the creatinine if I need to do a coronary angiography? Do they have iodine allergy is another one. Now, at the same time that you're gathering the information to see whether this is indeed an acute coronary syndrome, you will want to make sure that there are no other obvious causes of life-threatening chest pain. So you're going to get, of course, a good history, a good physical examination for this. And then we're lucky because we have portable ultrasound at Highland, and you can really help in the diagnosis, even as an intern, taking pictures and figuring out whether you have a large pericardial effusion, such as in this patient. Also, possibly imaging the ascending aorta and making sure that there is not an intimal flap, which should be suggestive of an aortic dissection. And then, last of all, in the right clinical context, for instance, a patient who has had a DVT or is just returning from a flight overseas, if you see that the right side is much bigger than the left side, then this may be evidence for pulmonary embolism. EKG, of course, is crucial once you have gone through all the previous steps and in the context of a clinical history, not alone. You can see ST depression, ST elevation, T-wave inversion, or nothing at all, and that can still be an acute coronary syndrome. And the most important thing, compared to priors, if you have the luxury that you have a prior EKG, because any change from prior EKG can make a diagnosis. What you have to know, though, is that 1 to 8% of acute MI have a normal EKG. 50% only of acute MI have diagnostic changes on their initial EKG. You can have a left ventricular hypertrophy, a left bundle branch block, and ventricular pacing, which may mask signs of ischemia. And an occlusion of coronary artery can happen without ST elevation. That's the case of a posterior infarct at times, or occlusion of left circ or diagonal arteries. And fewer people know that. So an EKG should be done while patient is still having chest pain, number one. And that's the importance of communicating this to your nurse as soon as you get the phone call. If the pain is worrisome and suspicious for an acute coronary syndrome despite a normal EKG, repeat the EKG 15 minutes later, because you may see things that you didn't on the first EKG, and that may make the diagnosis at that time. If the EKG is normal and the chest pain is very suggestive, with a patient having a crushing central chest pain radiating to the jaw with nausea, consider to continue the workup. Here is a patient with an acute ST elevation MI in the anterolateral distribution. Circled is the ST elevation, and you can see also reciprocal changes in the inferior distribution. That's a very typical EKG. Cannot miss this one. This is a patient with an acute posterior wall MI, and what you're going to see with this is ST depression in V2 and V3, and also ST elevation at times, not always, in the inferior and lateral distribution. This is very subtle. You may not even notice it, but it is there. Next step is to order some labs. And of course, outside of the general labs that probably the patient would have had by now, we need to order a troponin stat, troponin I stat. And then possibly 3 to 6 hours later is fine as well. But if you don't know initially that you are currently having an MI, it is better to repeat it early to be able not to miss it. It needs to be in a rise or fall pattern to make the diagnosis. And you have to know that troponin concentrations usually begin to rise 2 to 3 hours after the onset of an acute MI. To make the diagnosis of an acute coronary syndrome, you need at least 2 of the following. You have a history of angina, acute ischemic EKG changes, a typical rise and fall of cardiac markers, and also the absence of another identifiable etiology. Here are the three big diagnoses of acute coronary syndrome. Unstable angina on the left. The clot is not occlusive. Usually you find a 99% stenosis that looks like a ruptured plaque when you do an angiogram. You will have ST depression on the EKG or non-specific EKG changes, and you will have normal cardiac enzymes. There is no myocardial infarction. With the non-STEMI, same physiology, an unocclusive thrombus sufficient to cause tissue damage, but you will have elevated cardiac enzymes, and you will have similar EKG changes. With a STEMI, this time you have a 100% occlusion of the artery, and you will have ST elevation or a new left bundle branch block, and of course, elevated cardiac enzymes. So, regardless, if you suspect that you have an acute coronary syndrome, this is what you have to follow. Give oxygen, but only if the saturation is less than 90%. Nitroglycerin, sublingual, Q5 minutes for a total of 3 trials to see if the chest pain is gone. And then nitroglycerin IV for persistent ischemia, heart failure, or hypertension. A high-intensity statin, such as Lipitor or Crestor, at a high dose. And then a beta blocker, oral beta blocker within 24 hours if no heart failure, shock, or contraindication. At this point, I think by now you should have a good idea of whether you are in the context of a patient with ST elevation myocardial infarction or not. And if you have a patient with ST elevation MI, the first thing to do is to call the interventional cardiologist as soon as possible and discuss the case briefly for intervention via cardiac catheterization called percutaneous coronary intervention, PCI. You will also discuss whether it's appropriate to give anticoagulation or even clopidogrel. If the patient is having no ST elevation MI and is still having an acute coronary syndrome, then you're not off the hook. You will also potentially call a cardiologist and discuss the case, including anticoagulation or clopidogrel, and decide when an intervention will be appropriate. So I hope you are now ready to approach a patient as an intern with chest pain. We will hopefully see each other soon.